Factors and Ergonomics. The webinar will involve a presentation to start off with and will be recorded for your convenience so you can pick this up later. The presentations will be followed by a Q&A session and then a feedback poll at the end. Please note that your microphone will be muted for the duration of the session. If you have any questions as we're going through the presentations, please do enter these in the Q&A box and we'll endeavor to answer these during the session or at the end of the session. Unfortunately, we are unable to answer your questions during the webinar. Please do send us an email afterwards to the SHOT inbox and we'll forward your question onto the relative expert for a response. We have 3 panelists for this webinar. We have Dr. Alison Watt, who is the SHOT Human Factor and Ergonomics Working Expert Group member. We have Emma Milzer, who's the SHOT Hemovigilance and Patient Blood Management Specialist and Human Factors and Ergonomics Working Expert Group member. And we have Dr. Shruti Narayan, who's the SHOT Medical Director. It gives me great pleasure to hand over the presentation to Dr. Narayan now. Thank you.
Thanks very much, Karen. We are thrilled to kick off the year with this exciting and important session on human factors principles. Thanks very much to all of you for joining us today. Over the course of this session, we will explore the essentials of human factors and ergonomics principles, share some key highlights from the annual SHOT reports, and we'll also actually cover the human factors investigation tool and signpost the resources that are available. And all of you would be now familiar with human factors. So this is the definition that the Chartered Institute of Ergonomics and Human Factors define as the scientific discipline that is concerned with understanding the interactions among humans and other elements of a system. So it is all the factors that would be influencing the actions we take, the decisions we actually then make as well. And so, just to clarify a couple of things about human factors, first, it's about making systems as human friendly as possible. So, the mantra should be that we are making it easier to do the right thing and more difficult to actually then deviate. And it also means exactly the same as ergonomics. So people may be actually then just noting ergonomics as actually where the screen, the distance, this chair, etc., but actually is the same as human factors. And therefore, often you may be actually hearing this as HFE, human factors and ergonomics. Both of them are synonymous. And the other important thing to remember is human factors is used as a single phrase. It is actually, human factors is, and it is not a plural one. And so, as mentioned, when we say human factors, it is looking at everything that is actually then influencing us. So, it is encompasses all the factors that can actually then influence the behavior and performance. So what it allows us to understand is how we perform under different circumstances, why errors happen. So I think it is actually, looking at incidents through the human factors lens is actually then unveiling different, understanding of the system issues. And therefore, we can then actually then address the underlying system factors. Now, this is an image from one of the documents which actually highlights the complexity when we talk about human factors. You're seeing so many system factors, whether it is leadership, supervision, and the roles that we have, training, regulatory, and the interpersonal. So, the communication that we have, the workload and staffing issues and the safety culture, to the environment, the team, the task that is actually involved. All of these are actually then having an impact on the humans. And the other important thing is we often actually then just think about human factors in the context of investigating incidents. But it's really important right from the very beginning, whenever you're actually designing policies and processes, thinking from the user's perspective. User-centered design is actually then really important. And how are we conveying those instructions to actually then do the actual work? And how is the equipment set up? It's just like whenever you're making your tea, you actually then make sure everything is actually, easily located and easily accessible. So it is ensuring, again, you're applying the same principles to work as well. Also, it covers about how we are training staff, how we are providing that, safety training, access to the tools so that we are aware how we can actually then apply and become familiar with that. And also how we can work together to ensure an appropriate safety culture as well as an environment, so that what we are really doing is do more, more things go right most of the time. And also, of course, whenever incidents are actually then happening, then are we looking at it through the human factors lens and learning the key principles and addressing the system gaps? And therefore, human factors principles are important both in the reactive as well as in the proactive perspective as well. But it's also important. Often, what we actually then see is that they apply, they look at an incident through the human factors lens, but the ultimate conclusion is actually human error. Now, it is really important that when something goes wrong, we can't reduce the complexity of an incident to this simple pernicious term. So, it has become an explanation for almost any unwanted event, but we are looking at humans working in a complex system. So, what it has to actually prompt us is looking at what are the system factors that are, that are there. And an important thing in the safety science is actually, the language matters. So human error, as I mentioned, it is actually pointing to individuals in a complex system. But also, as Stephen Sherrock, another safety scientist who has actually worked a lot in the aviation, but also actually then has done a lot of work in the healthcare industry as well, who has also then defined the different types of work. Now, he has clarified that, whenever you're seeing this, as human factors, it doesn't mean that we are not holding people accountable or responsible for their actions. But what you're looking at is what is the normal variability? What are the complexity in the system which is actually resulting in the decisions that we take? And there is also that other end of the spectrum, which is recklessness, but neither of them should be actually labeled as human errors. So essentially, bottom line, language matters, but also equally when we apply the human factors, we are really understanding how systems work and we can address the deficiencies. And it's also important, although we are talking about this in the setting of the transfusion, these principles are vital for all aspects of patient care. So, it is not unique to transfusion. Whether we talk about medication safety or vaccine safety or preventing falls, safe patient care or even a donor care, then, you really are looking at application of the human factors. So we need to really ensure that all staff are aware of the human factors principle. How can we apply it in our day-to-day practices? How can we design systems, have documents and processes which are actually then suited to the users, having them simpler, safer, and then we are applying them to investigating incidents and using effective corrective actions and preventative action. Another factor which is actually increasingly now being recognized is that cognitive bias and also mitigation, and we cover that later in this session as well. And therefore, one of the key things that has been recognized is it's not just the technical skills, how to do our job, the clinical laboratory skills, but it's also about that patient safety, donor safety aspects, the leadership, the quality improvement, and also the human factors training. And this was recognized and was one of our key recommendations in one of the previous short reports that all staff should be actually receiving even the holistic training. It is not just the technical, but also non-technical skills. And during the pandemic, there was the first national patient safety syllabus that was released. It was released by the Academy of Medical Royal Colleges, and the UKTLC standards have also been updated to incorporate the safety culture. And this is the first NHS-wide patient safety syllabus. It is a multi-professional syllabus, and it covers all aspects of patient safety training. And what it says is everybody should have a basic understanding of the systems as well as the application of the human factors as well. Now, towards this, there are a couple of e-learning modules that are available from the Health Education England, and this QR code will be taking you to their page. And this is actually free to access for the NHS staff as well. Now, we have this graph is actually showing the cumulative data for short categories on the left-hand side, and on the right-hand side is the errors. But the main thing in the left-hand side is where you can see all the concentration of the bars. It is actually referring to the high percentage of the errors that are actually reported to us year on year. As you can see from the right-hand side, frustratingly, more than 80% of the reports that are submitted are due to inadvertent or preventable errors. And again, that is highlighting the complexity of the systems that we are actually working. But looking at this, now SHOT have been actually looking at human factors for more than a decade, from 2013 when it was actually first introduced. What it has actually then helped us understand is it is not just making a statement that errors are happening, but also giving a better understanding of what is resulting in these errors. So this is actually the summary of the key themes that we see, whether it is clinical laboratory or a combination of the errors. It often actually comes back to, do we have the right number of people, the right skill mix, and is it actually matched to the workload? We often see that there are actually deficits with that. There are also gaps in staff training and knowledge, as well as awareness of the human factors. But also we see, where the systems are actually built in a very complicated manner, and therefore people are finding workarounds. There is also actually the aspect of pandemic spillover of practices that we actually see, challenges with resources other than staffing. There are also IT equipment which have been hanging around, not being used or not being implemented appropriately. Or on the other end, there is over reliance on IT, and therefore there is a degree of complacency or warning flags not heeded. And of course, there have multiple reports of communication issues, including suboptimal handover at shifts. But also, we know that there have been problems with safety culture as well as leadership within the healthcare system. So, what it is actually really telling us is not just by understanding, okay, what are the gaps in our practices, but is actually then telling us why those gaps are and where we need to focus our efforts in improving and making better systems. So, this is actually just giving you a broad overview. But if I can hand it over to Alison, who will then take over the next part of the presentation. So, over to you, Alison.
Hi there, thanks, Tracy. So we're going to look at some of the data from the SHOT reports. And one of the things that we've suggested is that people use a framework or a model to investigate human factors when investigating incidents. And this graph just shows over the last few years, that's the number of people using it or planning to use a framework is slightly rising. But there's still a lot of cases that are being investigated without a formal framework. And if we move on to the next slide. So these are the sort of frameworks that people are saying they're using. Obviously, the SHOT questions is a good example of a framework, and it's based on the Yorkshire Contributory Factors framework. But it really doesn't matter what framework's being used. The important thing is if you're not using some kind of framework, you're likely to miss the system errors. And it can make it easier to start blaming the individual if you're not looking at all of the other factors. If we move on, so looking at the last couple of years of SHOT error reports, you can see there's quite a breadth of whether the contributory factors are situational or communication, etc. These are the large categories that we ask questions in on the Human Factors Investigation tool, the HFIT. And it's slightly, the 2023 is the red line. It was slightly worrying that it seemed to have moved a little bit to the left. In other words, looking more at situational and less at some of the other factors. And we were a bit worried because that coincided with taking away the scoring of whether people were concentrating a little too much on the earlier factors in the questionnaire and not looking at all the factors. So we're just encouraging reporters to make sure that you look at everything that may have contributed, or maybe not even contributed this time, but is a warning flag for something that could go wrong next time. If we move on to the next one. So these are the key recommendations from the last few years, suggesting that staff involved should be fully trained, particularly in an understanding of the human factors methods, and that investigations should look at all of those contributory factors. Historically, there was a bit of a tendency to look for a root cause. We talked about root cause analysis, but we should be looking now at everything that may have led to that incident or may lead to a future incident. And this year particularly, we've been talking about a restorative just culture. We'll come on to that in a little bit more in the next slides. But it's about focusing away from blaming the people involved in the incident and looking at the wider organizational learning, and particularly about repairing the trust and relationships after an incident. We can move on to the next slide. So if we're looking at safety culture as an aspect of that, and there are lots of contributory cultures, reporting culture, flexible culture, just culture, etc. And the combination of all of these attitudes leads to better values and perceptions so that people feel safer. There's psychological safety. They can report incidents. They can feel that things will be learnt from what went wrong, and there's no risk of people wanting to cover up or anything like that. So just to kind of compare restorative and retributive cultures, if you look on the left-hand side, I'm not going to go through all of these. This is in the SHOT report if you want to look at it in detail. But on the left-hand side, it's more about looking for blame, looking for what went wrong, what rule was broken, who did it, what went wrong. On the other side, it's more about who was impacted and how do we need to move forward. what can we do for making sure that anything that happened is met, the hurt is met with healing, and we're looking at the future, not looking at the past. We move on to the next one. So the main action from this year's SHOP report, the 2023 report, was that healthcare organisations should look to introduce this restorative just culture. Now you may have the power to do that in your own area, but the better thing will be if the whole organisation looks to have that as a culture across all of the organisation. We'll move on to the next one. So these were the key messages from 2023. It was encouraging to see that continued rise of frameworks, but if you haven't introduced something, maybe think about doing it. And within a restorative just culture, if you think about something like staff undertaking reflection, that isn't really an action that is going to have any future impact on the likelihood of an investigation, and it can be perceived as punitive. So if you're looking to have a restorative just culture, it's really moving away from that, concentrating on the staff member that made the mistake and looking at all of the factors that made them make that mistake in the first place. And therefore looking at things like longer term actions, and some of those are often difficult to implement. So things like an IT solution or getting more staff, but don't shy away from putting those into your improvement plans. And the important thing there is to keep monitoring that, maybe put it on the organization's risk register, or make sure that you keep monitoring those problems to see that they are resolved in the longer term. We move on to the next one. We're looking at actions and how do you put things right after an incident. You're looking for the CAPA, the corrective and preventative actions. And there's an intervention hierarchy. If you think about the things that you might put in as an action, if you stay down the bottom end of this diagram here at the people focused, as we were saying, reflection or more education or things like that, those are the less effective. What you're needing to be doing is looking at the system focused actions that you can put in, and particularly the forcing functions that actually make you do something or make it impossible to do the wrong thing. The more that you can change things to that, the safer the whole system will be, and moves it away from the people being responsible for the incident. We move on. I think we've got a case here that shows that. So I'll read through this, just give you a bit of time to think about it. So a patient requires a blood transfusion, but the electronic blood management system was not responding and not working. They went looking for another device. An alternative device was missing. The ICU's handheld device wouldn't print the barcode. And then the clinical team were trying to bleep the laboratory, but there was no answer. They confirmed the bleep number, but still no answer. And they resorted to going down to pathology and banging on the door until someone answered, to collect blood from the blood refrigerator urgently. We move on to the next slide. I think that gives us a bit of background information. So the investigation found that the blood bank's phone handset wasn't working well, and it was known to have needed replacing for 18 months prior to this, and that was following a previous incident. So that's a good example of an action that possibly hasn't been monitored across those 18 months. They knew the PDA was no longer fit for purpose. There was a business case done, but there were issues regarding wristbands, gender, and so that hadn't been implemented. There was a general lack of knowledge about the availability of emergency stock. And because of that, although this patient was actively bleeding, the staff were not aware that they could get the emergency units out. So they continued trying to find a working PDA to access the named units. So the CAPA on this incident was listed as a training plan to update, to include the use of the PDA and about emergency blood, and then providing specialist training for the anaesthetists, and the phone handset was replaced. But if you think about that, only the phone handset is a forcing function. That's an actual physical thing that means that the error is very unlikely to happen again. And although training is very important, there's not a mention in the CAPA about the PDA, and this may be long-term business case that hasn't been completed and it isn't being replaced. So it's a good example of how the actions need to be smart, so specific and measurable, achievable, and that can be difficult because we all know something like replacing a handset cannot be achievable, but you have to keep monitoring it. It has to be relevant, and the time bound is the bit that will require you to keep monitoring these actions until they're actually put into place. Otherwise, they're just sitting at the end of a report and never get done. So if we move on to the next one, this is another case, again, a missed opportunity. It was a female, a 10-day-old child, infant, receiving extracorporeal membrane oxygenation. The mother was O positive and the infant was A positive, which means that according to the regulations, the child should have been transfused with O positive blood, but group A red cells were issued on 2 separate occasions to the same baby. And following the initial error, staff were requested to update the standing order, but this didn't take place. The relevant SOP was very unclear with a lot of amendments. So the CAPA was to clarify and amend this SOP with additional flow charts, etc., for large volume neonatal and infant transfusions, which is where it gets to be a problem. But the preventive action that would have had the most positive impact was a forcing function, i.e. updating the IT. And again, it may be that this was outside their immediate ability. And of course, updating the SOP was very important and very useful. But you need to be looking at something that is actively going to prevent it in the future. And this is a couple of more examples of the intervention hierarchy of intervention effectiveness. And you can see things like down at the very bottom on the right-hand side, how many of us have either sent an email or received an email suggesting you're just more careful when you're doing these things? And realistically, that's never going to change. Who isn't careful when they're trying to do things? You always are, but mistakes still happen, errors still happen. But if you can put in a forcing function right at the top, then you stop that mistake being able to be made. I think if we go on to the next one, maybe, so a couple of examples of forcing functions from real life. So a forcing function is a design that prevents something from happening without the individual either taking a conscious decision or consciously considering what they're doing. And your day-to-day examples is you can't start a microwave without closing the door. And websites often want you to have a very effective password. So you can't create a password unless it's got an uppercase, a lowercase, a number, a character, etc. And it won't allow you to proceed until you've done that. So those are good examples. I've got a good personal example of sorry, brain's gone completely. Move on to the next slide. So a sample from a patient, this one was where a case where the individual staff member was asked to reflect, although actually that's not, again, not going to solve the problem. So this was a wrong blood and tube incident where the sample was grouped as O positive, but the historic group showed that it was an A. And it was identified because actually the staff member realized that they'd bled the wrong patient. But the samples had been labelled remotely from the patient with inadequate patient identification, patient notes. And this was because the ED had an escalation in process, extreme pressures, patients being seen in the ambulance corridor, and only one nurse and one nursing assistant. But the CAPA on this was for the member of staff to undergo retraining, competency assessment, and completing a reflection tool. And realistically, what needed to be done was the workload pressures need to be sorted. And we know this is nationwide, and we know that that's not a problem that can be solved easily. But this incident is not going to be stopped from happening again by that individual staff member undergoing retraining, especially if you consider it was the individual staff member that realised the problem in the first place. It would have been caught in the lab as well, but they realised their issue. So if we look on the next slide, we can think about where there are signs that the incident investigation and the CAPA may be suboptimal. So if you're concluding it's human error or blaming the individuals, if there are process failures in doing the incident investigation, we see this quite often, that incidents can't be completed because the member of staff was a locum and they've left, or the ED won't get involved in the investigation properly or whatever. If you're not looking at all of the causal or contributory factors, and the interventions that you then put in are not smart and don't appear to address those system vulnerabilities. And also, if you think about the impact, and that's often the best way to think about it, is how much will this action stop this incident from happening again? And if it won't, then there's probably a problem with the incident investigation and the outcome of it. So these are just some pointers to look at for where you may want to be thinking again. Can we move on to the next one? Oh yes, this is the end for me, sorry. I missed the marker to move on. So Emma's going to take over for now.
Thank you. My camera's got a life of its own, but hopefully that'll be on. Thanks very much, Alison. So as Shruti alluded to earlier, human factors and ergonomics isn't just important when investigating patient safety events, it's also increasingly recognised and used in design thinking. Next slide, please, Shruti. So involving and preparing staff when designing the workplace is really important, and thinking about individual characteristics. And we have some examples there for each section. So individual attitude, motivation, personality, etc. Individual skills, for example, the technical and non-technical skills. Group processes are important, such as cooperation and leadership, and also quality and safety outcomes and how these will be measured. Next slide, please. So the example we like to use quite often on a personal level in human factors is, as Alison said earlier, about this making a cup of tea, or Shruti, I think it was. So if you think about giving an instruction to somebody else to make a cup of tea, we'd all do it probably differently. Would you put the milk in first or afterwards? Hopefully first, never afterwards. But you catch my drift. And that's also really important when we're looking at designing systems in the workplace. So this example is one of installing a temperature controlled fridge. And it's important to consider the impact on all areas and staff involved. So we have examples here of the laboratory impact, financial, process updates that are going to be required. Also for clinical staff, they'll require training, awareness of the change, involvement of all the relevant personnel, which can include estates, your portering, etc. They've got really important roles to play. Things like, do all the appropriate staff have the correct access to all the sites? Doing a site survey to see if that's suitable. And also downtime procedures need to be put into place for both laboratory and clinical staff in case the fridge should fail. Got things to think about from the patient safety side of things and confidentiality. For example, if units are being removed from a fridge in a public facing area, is there a risk of those labels being viewed which could breach patient confidentiality? And just to be mindful that a holistic approach is essential, and it should always be considering human factors and ergonomics when setting up systems. Next slide, please, Shruti. So we've discussed a little bit about cognitive biases awareness, and essentially cognitive biases are cognitive shortcuts which are used to aid our decision making. There's increasing recognition that they can contribute significantly to errors in healthcare, so they're flaws or distortion in judgment or decision making. And it's really important that staff should be aware of cognitive bias when investigating incidents as well, and aim to investigate incidents impartially with an open-minded approach. Next slide, please, Shruti. So as already mentioned, cognitive bias can affect all of these things: memory, decision making, behavior and judgment. So it's really important for us investigators to be aware of their own cognitive biases and assumptions, especially if they are working remotely from the area where the incident has occurred. And sometimes walking through an incident end to end can be really beneficial in incident investigation. So here are some great examples of cognitive bias. You can have a read of those. There may not be time to go through them all, but they can be conscious or subconscious, and cognitive bias can be affected by several factors such as emotion, social pressure, mental shortcuts. So to give a few examples, we've got a anchoring bias there, bandwagon, confirmation bias, and fundamental attribution error. An example of a bandwagon effect is Bob thinks the world is flat because everybody in his village thinks the same. And how might that translate to the workplace? Well, example we've got here is that a phlebotomist handwrites the samples away from the bedside because since they came into the post, they've observed that's what everybody else does. So that must be the right practice. So you can see how this can have this bandwagon effect. We've got, sorry, Ruth has moved on. This is an example case study, which happened in one of our SHOT reports. So where cognitive bias can contribute to errors in decision making. So a patient received 2 units of FFP and 2 units of cryoprecipitate out of hours, and in error, they were prescribed those, and in error they actually received 4 units of FFP. This was prior to a procedure. So what happened here was the cryoprecipitate was stored in the wrong location. It was stored in the freezer where the FFP was stored. The staff just assumed that all the units were FFP. Obviously, they look quite similar as well, don't they? So if you're rushing, you might miss the label to say, you know, that they are different. And they assumed that they would be in this place. And the staff collected the impoundment, and the administration check also failed to identify the error. This was noticed the next day. So again, you can have these issues where components look very similar or they're in the wrong place as to be expected by staff. Human factors in IT is incredibly important as well. There's been a lot of ongoing work around human factors in relation to IT systems, and these apply to all stages in implementation, planning and operation of IT systems. It's essential when setting up systems to consider who and how the system is to be used and to consult the staff before that change happens, not just afterwards. And also that systems are used as intended, so any unsafe workaround should be avoided. There was a recommendation in this year's annual report around recommendations for IT. Sorry, I've moved on to the next slide now, Shruti. And this was that when introducing new IT systems across any part of the transfusion pathway, human factors and ergonomics should be considered to gain all the possible benefits of the technology for staff as well as for patient safety. Next slide, please. So I'm going to move on to the SHOT Human Factors Investigation Tool, or HFIT as we abbreviate it to. You may be familiar with this. This was launched back in 2016. We originally asked reporters to give a score to each section, but that's been removed. It's been evolved quite a lot over the last few years. The scoring was removed altogether in 2021, as reporters actually told us they found it difficult. And when we thought about it, the main thing we want to be considered is the contributory factors. So the scoring has been replaced with a simple yes or no to encourage consideration of the contributory factors. Next slide, please, Shruti. So there are some slight changes for 2025. Each year we do review it and we take feedback from reporters, and we try and make it more user-friendly while also trying to optimise information for the incident specialists around the human factors involved and ensure that learning is shared. And it's a very fine balance, really, because obviously we want the tool to be as human factor friendly and user-friendly as possible for our reporters. So for the main contributory factor sections, which are there at the top, so communication and culture, local working conditions, those are largely unchanged, but you may just notice some very subtle language changes. Next slide, please, Shruti. Just a top tip, really, if you are a reporter and you do complete these sections, if you hover your cursor over each question, under each section, I've tried to illustrate that with a blue arrow there, it will pop up with these tooltips. So if you're stuck and you think, I don't really know what that question means, if you hover your cursor, it will bring up some nice examples, which might hopefully just jog your memory and think, oh, actually, that did happen. And this is available on all the sections. Next slide, please, Shruti. Just to mention that one thing that is new for 2025, and this is this actions section, which is illustrated at the right-hand side by a blue arrow and a circle there. So this is completely new. It's up to 3 main actions can be added by reporters, and reporters asked to add a brief description of the action that's been taken, and then select the type of action effectiveness. So the choices here are forcing functions, so some of the things we've talked about in previous slides, automation and computerization, simplification and standardization, rules and policies, reminders, checklists and double checks, and education and training. It's not a test, there's no right or wrong, it's simply to help consider the actions that have been put into place and their effectiveness, bearing in mind all the information in the previous slides around the intervention effectiveness hierarchy. And perhaps when you're unable to implement these actions yourself, for example, a forcing function because they're too difficult, they can be escalated or put on the appropriate risk registers. Next slide, please, Shruti. Here are some examples we've put together. These aren't in any particular order. So an action there, for example, of creating a training plan and competency assessment covering fridge alerts and delivering training to all staff would be an example of education and training. And then an example of a forcing function might be ensuring the LIMS does not allow issue of ABO incompatible red cell units. We are on the verge of releasing an updated tuition package as well. That's being revised and it will be ready by the end of January, and this will have these examples in. So that'll take about 10 minutes for you to look through. So moving on, some suggested resources for human factors. We have lots on our website, in particular our Human Factors and Ergonomics webpage, and that can be accessed by scanning that QR code. We have shot bites, we have previous webinars and shotcasts. I've already mentioned the tuition package. We have videos and an e-learning module, which is accessible through e-learning for health. Also, just a quick mention of our human factors courses. We've run these very successfully over the last couple of years. We'll be running more in autumn of this year. Just look out, either sign yourselves up for the SHOT newsletter or keep an eye on the website. We can't keep a waiting list for these due to GDPR regulations, but as I say, just keep an eye out for those. Next slide, please, Shruti. Just a mention of the new SHOT website. So this is very exciting. This is going to be launched this week. So we have an all singing, all dancing new SHOT website, which we hope is a lot more user friendly. It's going to have its own dedicated human factors page, as the previous one has done. A really lovely function of this, which you can see in the image on the right hand side, is the search facility. So if you're looking for something in particular, like the human factors webpage or a shot bite, you can type that in and then it will bring that up. So do look out for that later this week. It's Wednesday, the day of the launch. Also to mention the Transfusion Training Hub, which has lots of SHOT and further resources on as well. You can scan the QR code to access those. And for anybody who's accessed it, I'm sure you'll agree that's a fantastic resource for all things transfusion. And lastly, the Royal College of Pathologists. So we have a pathology portal, which again can be looked at by scanning the QR code. These are all free to access for UK and international users. And there are lots of details on the link provided. And these are an award-winning compendium of lots of resources. Next slide, please, Shruti. So forthcoming events, please do look out for our further monthly Meet the Experts webinars from SHOT on the website and also via the newsletter. And also just to say that our annual SHOT Symposium is taking place on the 11th of July this year, and that's going to be in Birmingham, and it's sure to be a fantastic day. So early bird rates will be made available and registration will be made available very soon. Next slide, please. And that's the end of my slide. So it's over to Karen now, who's going to facilitate the question and answer session. Thank you.
Thank you, Emma, and thanks very much to Shruti, Alison, and Emma for those presentations. And I'll hand over to Vera, who will be answering the first question. Please do put your questions in the Q&A section. We're here to answer them. You've got us all in one room at the moment, so it's much easier to answer your questions now. Just type them in for us and we'll read them out. Over to you, please, Vera.
Thank you, Karen. So the first question that we have on a Q&A is how do we include these aspirational interventions, like a new IT system, which may take a long time and money to action? We may not be able to address it ourselves. Who would like to take? Shruti?
Yeah, I can kick off and Alison can also actually come in as well. So I think, as we mentioned during the presentation, so you may identify that IT, for example, is the solution, or even say, for example, we need an extra member of staff, but it may not be like on one hand, we say that it has to be smart when you're actually then thinking about the actions, but, on the other hand, this may not be immediately feasible, completely get those challenges. But it is important to, at a system level to be able to actually escalate that, whether we are able to actually then say, these are the number of incidents that have happened due to the lack of poor IT, and that can actually then be escalated upwards. So I think depends on the mechanism within each of the organization. It is actually ensuring that there is visibility of these incidents where a forcing function or a form of a system solution would have actually then helped address these errors or incidents that are actually then seen, making sure that that is actually escalated, and visible on the risk register as well. That is actually all helping us to get that, helping you all to get that necessary funding, approval, prioritization, so that the necessary resources can be put in place. So I think that would be what I would suggest. But Alison and Emma, I don't know if you have anything else to add to that.
Yeah, I think really pretty much the same. I think the important thing is not to shy away from actually putting those actions onto an action plan, and to keep monitoring them, even if it is going to take years to get a new IT system in, or if you know that you actually have no hope of increased staff, if you don't keep putting it down as an action, it will never get flagged up as being a necessary intervention.
Yeah, and I think as well, my experience as a TP is that transfusion, unfortunately, can sometimes be quite siloed. So, the more you can almost shout about something and actually get it escalated beyond the transfusion department by doing these things, such as risk registers, then that's really, really essential. And that can only be done if we actually identify what is actually needed to be put into place.
Thank you. We have another question. I think it's more of a suggestion and a question combined. ED pressures are out of control of the transfusion teams. SHOT need to be realistic on what transfusion teams can do and influence on. If SHOT has actions they require trust to implement, they need to contact chief executives, as pushing this onto the transfusion team or transfusion practitioner ends up going nowhere. I think that's very much based on what Emma was saying, wasn't it?
It is. And actually, thank you, whoever has actually answered, although it is coming across as an anonymous attendee, but we share your thoughts. One of the things that I would like to actually stress is a post-infected blood inquiry. There have been a lot of discussions going on as part of the IBI implementation groups as well. We do recognize that the governance for the transfusion needs to be embedded along with other safety aspects within the hospital. So it has to not sit in a silo, but to be actually then built in. And also, we are aware that, you know, if there is any kind of a communication or a safety communication that comes, it just falls on that lone TP or a consultant who is actually then in the trust. So one of the things we have been working on, you know, please wait for all of these to actually come through. But this year, what we are actually going to be working on is how, working with all the regulators as well as other transfusion stakeholders, including the transfusion committees, we are trying to actually get a infection control like of a system for the transfusion, so that you have board level oversight, integrated care board oversight with respect to the systems in England, so that there is actually accountability at that executive level and support, as well as hence prioritization of the resources to the transfusion. This is all in discussion, and the implementation groups have representation from all the stakeholders, including TP representation as well as laboratory representation as well. So please, you know, bear with us, because we do know that these are the areas that really need to be strengthened. So, you know, hopefully with the infected blood inquiry recommendations, there is going to be a more joined up working and transfusion safety considered alongside other aspects of patient safety, with a better governance structure and oversight as well.
Thank you, Shruti.
Thank you. So the next question, it is, do you have the reference regarding not using reflective statements in reviewing incidents? As you have said, it is more punitive.
I think there are a couple of clarifications. Maybe Alison and Emma also will be coming in. What we are trying to say is, you know, reflective statements is the only improvement action, is actually not really going to help solve the problems. Now, they have a role. You may also have a team reflection going on, like, for example, in a debrief as well, when you actually then have after a major hemorrhage. So that is more a reflection of what went well, what could have been better, and does the current system work? But what we are trying to say is that we often actually then see that the staff member was asked to reflect, and that is actually the corrective action that has been put in. That by itself is not going to actually really, it is not really considering the system factors or the complexity in which the individuals will be working. So having that alone as an improvement action does not actually then prevent the recurrence of these incidents in the future. So they have a role, but they can't be. And the thing is, when you're actually then having no other improvement action and only asking the individual to reflect, it is then going to be perceived, oh, I'm the one who has made the error. Ultimately, errors happen either a single error or a combination of the errors. Ultimately, an individual within the system has actually done that. But the question that we are asking is how did the system allow that to happen? How can we actually make systems better? So I think Emma and Alison, if you have anything to add to that as well.
Yeah, I think so. I mean, one of my top tips generally for people investigating incidents is put yourself in the shoes of the person that made the mistake and think how you would feel if you were the person. What would you be saying? I made this mistake because we were overworked, I didn't have the right piece of equipment, I hadn't had the right training, etc. And then consider whether reflection is actually going to change your practice hugely. And more importantly, is your own reflection, would your own reflection actually stop that incident happening again? So it's not to say that there isn't a place. Occasionally there will be, you know, a place for that to be an action, one of the actions. And as Shruti was saying, a team reflection can sometimes be quite valuable. But if you're thinking about something that actively stops an incident from happening again, you are trying to look for the more forcing functions and the more system related functions. And I know that that can be very difficult to be thinking about things, because it's very easy to focus on, but that person was just such an idiot. How did they make such a stupid mistake? And you can't get past the individual. But it is about using some of the tools that we've suggested today to be trying to look at the system factors beyond the person, and why did it seem like a good idea at the time to do whatever they did or didn't do.
I think there's a lot to be said for people's own previous experience around reflection as well, and you know, safety culture, as we've talked about. So if you've perhaps been used to over the years working, and you know, reflection has been used as a bit of a punitive tool, or you go away and reflect about what you've done and come back with a statement, then I think it can be all about language as well. I think a nicer way, like Shruti and Alison have said, you know, team reflection can be really good, but perhaps to call it an after action review, or, you know, an after event review is probably more. So you still, because I think asking teams to do that can be quite useful, or even individual, especially just to recollect the, what's gone on, because sometimes by the time you come round to investigating an incident properly, 2 weeks could have passed because that member of staff might have been on annual leave. So I think a lot of it comes down to language and how it's used and the culture as well.
Thank you.
Thank you. That leads quite nicely into the next question we have here about actions language is not user-friendly for anyone that's not attended the webinar, even for people that have. You need to explain somewhere what each of these mean within.
Yeah, no, thank you, Karen. I think any kind of feedback would be actually really useful. So this kind where, we can actually then include that in the tips. Now, as Emma mentioned that, I'm assuming this is actually on Dendrite when you're actually entering, whether they can be actually coming up as prompts, but also as the HFE training package, we can make that clearer with respect to the intervention hierarchy, the actions that are actually then needed. So, please do, we welcome all suggestions as well as feedback, and please do let us know how and what we can actually improve in the resources that we provide as well.
Thank you, Shruti.
Thank you. There's one question that I would like to look at. So is safety culture something that can be measured? And if so, how do we do it?
Yeah, that's a big one. Yes, safety culture. There are both, you may argue that, this is qualitative aspects. So there is both qualitative and quantitative. How do people feel and all the different aspects, like Alison showed as well. How confident are we that whatever we can raise concerns and our concerns will be heard? So there are different aspects of the safety culture that we can, including civility, which is actually prevalent within the team. So people may be familiar with the laboratory safety culture that we actually carried out last year, along with UK Transfusion Laboratory Collaborative and MHRA as well. So there are standard templates, but there are also different aspects. Even if it is actually there are certain concerns that you have, you can actually then say explore civility in your workplace itself, and that is a separate questionnaire. NHS staff culture survey also does actually look at some aspects of the safety culture survey. But yes, so it can be measured. And what is ideally, and even one of the recommendations from our safety culture report is you need to have that baseline measurement of what are the problem areas in your place. Have a safety culture that you can actually monitor on a regular basis. It has to be both organization wide but also within teams, because it may be different within teams. So you're actually then asking the questions and providing that confidence that the staff can also respond and be heard, and and they are listened to as well appropriately, so that actions are actually then being taken. There is a Health Foundation document as well from nearly a decade ago, which actually then covers measuring and monitoring safety and what are the safety culture questionnaires that are in place as well. So we can share that link, we can share that resource with the webinar recording later.
Thank you, Shruti. Another question from an anonymous attendee. How can we include human factors in incident investigation?
Yeah, and I think Alison also can come in, please. Okay, Alison, you start, please.
Yeah, I was just going to say, I think the most useful thing is to have some form of framework. I mean, the easy one that everybody can access is the shock questions. And if you're not aware, there is the tooltips on the website, which is a list of all of the questions we ask and the tips that go with them that Emma was talking about. You can hover over the tips when you're actually in Dendrite, when you're actually reporting it. But you can also download that whole document in advance and use that as your framework. Or there are plenty of others, and you may have just your own local frameworks of incident investigations. But if you have prompts in those frameworks that are asking you to think about the questions, so they're asking you, what were the local working conditions like? What was the organizational impact on this incident? Then that gives you the opportunity to think a little bit beyond the immediate.
Thank you.
Yeah, thank you.
Another question. How do we measure if interventions have been effective?
Yeah, thank you. And I think it is a couple of things. One is you're going to monitor whether there are near misses relating to that incident that has happened. Also, how many incidents have happened. You may have an organizational or a team level audit that you're actually doing as well. So it is, again, depending on the type of intervention, you're actually then able to have quantitative and qualitative metrics to actually then ensure how effective your interventions are. Now, it may not be realistic to actually then see every type. So for example, you have had a series of VBITs, wrong blood and tube incidents. You have actually then looked at it comprehensively and you have put systems in place. So what you're then trying to do is actually then trending those incidents to actually then see with that intervention, has that actually made a change in the number of VBITs? And, so, or even the number of ABO incompatible transfusions that have happened. Now, it doesn't mean that, okay, you have put in one intervention, there could be another error that was actually then happening in the background. So, but you're really looking at what did it try to improve? Has that actually improved? So it is only through trending that you can. Sometimes it's also actually then useful to get the feedback. Not sometimes, actually quite often, you're getting the feedback wherever you're put in an intervention, understanding what is the impact that it has had on staff, on patients, as well as donors. If it is actually in the blood services, is also really important, because what we may perceive as a solution may have some other unintended consequences. So it is actually then important to actually even accept and learn and understand from those.
Thank you, Shruti. Anybody else want to come in? Alison, you have...
Yeah, I think it's also about actually monitoring that actions have taken place. So if you look at some of the case studies that we looked at today, things were known to be wrong from a previous incident. And then that action, presumably there was an action from that incident, either hadn't been implemented or hadn't been implemented fully. And I think you need to start at the very basics of an incident report doesn't end with, and here's the action plan. It ends with, and here are all the actions completed, or put into a position where they're being monitored so that we can continue to make sure that everybody remembers this was an action from a previous incident and may lead to another incident if we don't fulfill the action that we asked for.
Yeah. And can I just also add, I was just looking at all the other pending questions because I'm just conscious of the time. And I see that somebody has actually then put in a statement that we seem to be out of touch and we want, and what is happening in the wards as well as departments in everyday working. I would like to really assure you that, we may be working full time away from a hospital setting, but we want to be responsive. We are responsive, we think, as to how things are going on in the ground. And we get that through our, through all of you as reporters, through members in our short steering group and working expert group. But we also want to hear from you more in what aspects that you feel that we want to be, we need to learn more. So please, can you actually then email us, let us know where we are going wrong or how we can actually have a better understanding of what is going on in the hospitals. But I think, it is, we do not diminish the challenges. We are not undermining any of the work that is already going on. And we really look forward to working with everybody. And as I said, I think with respect to the infected blood inquiry report, there are lots of work that is going on in various subgroups, and SHOT are actually supporting various work streams across UK. And I see another person has put a note about a gap analysis completed, but it was completely ignored. Again, we can hear you, but there is, in England, there is actually a combined working group with NHSBT, NBTC, that is the National Blood Transfusion Committee, as well as NHS England. And we are part of many of the subgroups as well. So hopefully change will come. And there has also been a request for funding support as well.
I think that was that. It was, I got the impression it was ignored in the trust as well. And just to mention, I know we're running out of time, but one thing we do facilitate as well is workshops across the UK. So we've done those previously, and we have another round coming up, starting with Wales at the end of the week. And that's to really get this bi-directional feedback about what's happening out there, what people want from SHOT. So, we are trying to think of different methods to try and really get that feedback as well. And for those people who aren't familiar with the kind of setup of SHOT, as Shruti said, we are supported by a very active working expert group. So we have experts in each kind of field, and they really do keep us in touch with what's happening in those particular areas as well. So just to make you aware of that.
Thank you, Emma. And thank you all for those great questions. I'm aware that we didn't get around to answering some of them, so please do pop them in an email to us. And we will certainly get back to you if we get those emails. We'll try and download these questions off our webinar. We might be able to look at them afterwards and get back to you. But thank you very much. We're now going to host a poll, which will appear on your screen shortly for you to answer the questions. Please answer the questions because actually it helps us and helps to inform our educational sessions going forward. Again, just a reminder, this session has been recorded and it should be uploaded onto our website soon. Please do mention our website. There are lots of reports and resources that are freely available to help you with your educational activities in the hospital, and these are regularly being updated. And as Shruti said, your comments and suggestions are, of course, extremely welcome. So please do pop us an email. We'll remain confidential, so please don't feel afraid to email us. And as mentioned by Emma, our SHOT Symposium will be held next year in July on the 11th, and our registrations will be opening shortly for those, so please do keep an eye out. Finally, a huge thank you to all our speakers today and to all of you for joining us. We know it can be difficult to join these things in your organizations because you're so busy, and we hope to see you again very soon. Thank you.
Thanks very much.